Thanks for inviting me to speak to this audience, and I can tell you I've learned an awful lot already today. I have a very big interest in smoking in pregnancy, and I suppose I'd have to say it arose out of a different zone that I was in. I was looking at fetal growth restriction and particularly looking at aspirin in relation to that, but we merged into cigarette smoking and I've taken that on, and I think it's a really important topic, and I also think we've made good inroads, but we have a lot to do in relation to improving maternal outcomes in women who smoke and in figuring out what's happening to women who vape, and hopefully we'll chat a bit about that afterwards. And I suppose, what's the scale of the problem? It's huge. 10% of the Western world smoke, and 1 in 10 women smoke in pregnancy. And it's estimated that if all of the women in the US stopped smoking who smoke in pregnancy, there would be a 10% reduction in stillbirth and a 5% reduction in perinatal mortality. So it has huge impacts on pregnancy. And I suppose it particularly affects younger women, less educated people, and those who are more socially disadvantaged. They're more impacted by cigarette smoking. And young, less educated women are less likely to quit smoking in pregnancy. And I think everyone in the room here who's involved with smoking in pregnancy will have seen that in their practice. Moreover, it is also a marker of mental health issues. 30% of women who smoke will have mental health issues. And so I consider smoking in pregnancy to be a red flag. And it is a marker of risk, and it's one that we haven't paid enough attention to. If we look here at society and societal issues, we can see that the demographics of smokers are that they are largely in an unemployed or underfunded population. Wealthier people do not smoke as much, more deprived and unemployed people do, and very often it's a feature of their background situation. And we have to take that into account. We're talking about helping them to quit and looking after them in pregnancy. We don't have very good data on smoking in pregnancy, and I'm sorry to say that as Clinical Director of Obstetrics in NWHIP. We certainly record it at the COOM, it's recorded in other places, but joined up information on smoking in pregnancy is hard to get. Now, we did have very good data from the National Longitudinal Household Survey growing up in Ireland, which said that in 2014, 17.6% of women smoked in pregnancy, and I can tell you that at the COOM today, about 9% of women smoke. So that's a big inroad. But I can also say that the women who do remain smoking are the hardcore smokers, and it's hard to get them to stop. So it is great when they do stop in pregnancy for the reasons that we'll discuss. And so we should be now, I suppose, greatly proud of our national profile on cigarette smoking and cessation. We were the first country in Europe to ban smoking coal, and that had a direct effect on improved outcomes from deaths due to respiratory disease in people in Ireland. And then the workplace ban was a huge improvement in terms of public health when it came in 2004. And we have good data from maternity outcomes that the rates of admissions with very early and low birth weight babies fell dramatically in the year following the workplace ban. And that's because passive smoking is an added risk to women who are pregnant. So it increases the risk of adverse outcomes and low birth weight by about 30%. And that was an example of policy impacting healthcare, and that has been a huge improvement. In addition, the rates of smoking nationally fell by about 12% in the year following that ban. So that was huge, and that was a first in the world achievement. So well done for that. I want to go into the pregnancy realm, though, because where are the exposure sources for women in terms of smoking and nicotine? Well, we know cigarettes, and we are very much invested in trying to drive down the rate of cigarette smoking in pregnancy, and it's a hard task. There's also smokeless tobacco. We don't have huge populations of that. That will be snuff or chewed tobacco, but they do, we think, impact on fetal growth from studies that we have. Second-hand smoke, as I've already said, is really important, and that's why the smoking in the workplace ban was so important, because environment, if your partner smokes in the home, that's really important in terms of added risk, because that all gets into the mother's circulation and gets into the placenta. Nicotine replacement therapy, well, we give that, but it's very graduated. It's given in a very safe way. We know what we're giving, so I suppose we would say that's probably better than smoking. We're not so sure how effective it is, I would say. And then e-cigarettes. And e-cigarettes are becoming very big because they are practically exploding in the teenage population. We're seeing more women come in on e-cigarettes. And the issue with e-cigarettes is you just don't know how much they're taking or how often they're taking it. And we do know that that's all getting concentrated, and we'll talk a little bit more about that, is getting concentration in the fetus. But let's just move to, I suppose, the greater of the two evils, which is the cigarettes, and certainly there are other constituents in cigarette smoke. It's about 5,000 or 7,000 chemicals in cigarette smoke, so there's a lot of bad stuff in there. We're going to focus on the ones that we do know a bit about, carbon monoxide being one, same as exhaust fumes. You inhale carbon monoxide, it is rapidly transferred across into your bloodstream, directly into the placenta and concentrated in the fetal placental unit. It binds the baby's hemoglobin, so it kicks off the oxygen, the baby becomes hypoxic. That has detrimental effects across development. So in later pregnancy, growth, undoubtedly, and in early pregnancy, we don't know what it does. Is it teratogenic? It probably is. It probably affects the development of organs, and we will show that there's evidence for that. And it may be related to other compounds, but it certainly is plausibly related to carbon monoxide. But principally, it leads to fetal hypoxia. Fetal hypoxia leads to stunting of growth. Cadmium is another byproduct of cigarette smoke, which is really, really important. It's a product of refinement from heavy metals such as lead or iron ore, and it is used for paint making and in batteries, and it's a very toxic agent. It's absorbed in the diet, and in cigarette smoke about 30% of cadmium is absorbed. And what's significant about cadmium is that it is concentrated in the placenta, so it goes into the placenta and stays there. So you've got a heavy metal in the placenta, and that has been linked in the Eden cohort, that has been linked to fetal growth restriction, where they measured in about 900 women, they measured cadmium levels at 2 time points in pregnancy and found that cadmium levels were inversely related to birth weight. In other words, they were associated with fetal growth restriction. So there are bad actors in cigarette smoke, no doubt, and there are lots of them, and we don't know much about a lot of them. But the one that we do know a bit about is nicotine, and nicotine is the reason why we're all addicted to cigarettes. So it's an organic compound, we all know that, highly addictive, very hard to give up. Cigarettes, they say that if you look at a population that have stopped smoking, only about 10% remain off cigarettes at the end of the year. So you can see how hard that is to quit. And I think that we must recognise women who come into pregnancy are already highly motivated to stop smoking. So the ones that remain smoking in pregnancy, it's really hard to affect behaviour. And I'd say we have to acknowledge that when we look at our outcomes and our results, and it's important to know that. It's not to give up on them, but it's to say that they are a group of people that have lots of issues, and one of them is cigarette smoking. It's a known carcinogen, it's extremely toxic, and it's concentrated in the fetus, and that's a big concern. We'll talk a little bit about that, the concentration of nicotine in the fetus, and what does that mean? You know, in terms of cigarette smoking, it's a dose response. In terms of nicotine replacement, it's very controlled. And in terms of vaping, we do not know. And we're going to talk a bit about how we might find out more about that later. So if we focus then on pregnancy and start early in pregnancy, Rodek and Hackshaw did a very nice systematic review of studies that looked at the teratogenic effects of cigarette smoke in pregnancy. So teratogenic means altering the structure, so creating physical defects and malformations in babies. And they found that there were several associations, strong associations, that have been confirmed in serial studies. And if we look at these, there's evidence of cardiovascular defects. Now, these do not tend to be the major structural abnormalities, but ventricular septal defects, but still cardiovascular. Craniosynostosis. Craniosynostosis is where the skull bones of the baby is fused, and that's problematic after delivery. The brain can't grow. It requires surgeries to release, and that's been highly associated with cigarette smoking. In addition to that, orofacial clefts have been consistently associated with cigarette smoking. So cleft lip and palate is highly associated. Gastroschisis, we all see gastroschisis in smokers. It's thought to be due to vasoconstrictor effects of nicotine, but perhaps other things. It's also associated with other drugs such as cocaine or amphetamine use, and that's consistently seen in smokers, and also fetal growth restriction in relation to gastroschisis. Cryptorchidism is less seen in pregnancies or in people who smoke, and that's about the only malformation that's seen in a lesser degree, if you like. There are other complications, and they would be preterm birth, and related to preterm birth would be premature rupture of the membranes and infections, threatened preterm labour and preterm labour. I want to draw your attention to two, though, that are really important. One is placental abruption and one is stillbirth, and we'll talk about those in more detail in a little bit. Placental abruption relates to when the placenta separates from the uterus, there's massive hemorrhage, and often the baby dies or is delivered in poor condition. And stillbirth is where the baby dies pre-delivery, after 24 weeks in a normally formed baby. And we'll see that stillbirth rates are greatly increased in women who smoke. So there are bad things that happen to babies of mothers who smoke. The other issue with smoking is that it leads to subfertility, not very often known. There's a lower rate of success with IVF and a slower time to become pregnant if you smoke. There's an increased risk of miscarriage rates. And also, after birth, mothers who smoke are less likely to breastfeed, but they're also more likely to stop early. And the constituents of breast milk are altered, and they're not as good in mothers who smoke. So the baby's deprived in that way also. I'm going to step back to look at abruption and placental disease. And my interest really as an obstetrician, and I've sadly now counted, I've worked over 35 years in obstetrics, so I've seen many babies die from placental abruption, and very often that's related to cigarette smoking and growth restriction. And how do we prevent that is one of the big issues, I suppose, that's still relevant to us. So we see placenta previa, which is where the placenta lies low. We don't know why the placenta implants in an abnormal place in smokers. But we also see placental disease. And so in the bottom of the picture there, you'll see there is a sort of a section of the placenta, and the dark areas in that placenta are areas where the blood has stopped flowing. So that means the placenta is infarcted, a medical term for where the blood is cut off. And therefore, the perfusion in that placenta is less. And we often see that in growth-restricted babies of smokers, that the placenta is diseased. If the placenta gets diseased enough, for some reason or another, it separates from the placental wall and you get an abruption. And at the top of the picture there, you see that black currant-looking jelly stuff. That's an abruption behind a placenta in a mother probably delivered emergently for placental abruption. These babies don't do well. They often have catastrophic brain injury, or they often are born dead. So this is the problem with cigarette smoking at the sharp end. I want to move on to growth restriction, which is where I started in terms of looking at smoking and pregnancy. So low birth weight and intrauterine growth restriction is something that we try and assess at every visit. So at every visit, we look for hypertension, we do blood pressure and protein, looking for proteinuria. But we also look at the fundal height. They're the predominant things that we do. We look at the fundal height. Why? Because we want to know, is the baby too small? We're not too worried about big babies, in fairness. They might be diabetic, but the small babies we need to worry about. And the small babies have problems. They have problems because if they're not detected, they can die, or they can undergo birth injury, trauma, or they can be damaged postnatally from not being able to oxygenate during labour. And we see it time and again. It's not something that's historical, even though we knew about this since 1957. We see growth restriction in cigarette smokers. It's highly associated, at least double. We see it in second-hand smoke. It's 30% over the average in second-hand smoke. And we see it in smokeless tobacco, which begs the question, is it nicotine? And I think the jury's still a little bit out on nicotine. We'll talk a little bit about that in a moment. The mechanism is unclear. It could be carbon monoxide, could be other toxins, it could be nicotine, but it's certainly there. And so I'm going to show you a little picture here of two babies. So the baby on the right might be a diabetic baby because it's nice and chubby and big, and you can see its big tummy. The baby on the left is growth restricted. Not necessarily a smoker's baby, but a growth restricted baby. How do I know that? It's tiny. The head seems to be relatively bigger than the tummy, so we know that that's the usual pattern with fetal growth restriction. So when the normally formed baby sees that it's not getting enough nutrition, it's very smart. In evolutionary terms, it shunts blood to the brain. It says, my brain is the most important part of me. And then it decreases blood flow to the skin, to the subcutaneous fat, to the liver and kidneys. And so you'll get a thin little abdominal circumference and a nice generous head circumference and a small baby. How do we measure babies? Just for those who don't know anything about obstetrics, we do a scan in the third or second trimester to look at growth, and we measure three things. You can't weigh the baby, so we measure three things. We look at head circumference, we look at abdominal circumference, and we look at femur length, and we get a formula that gives us an estimate of fetal weight, which is fairly accurate, actually. So we can tell if this baby is big or small, if this baby is globally small, or if this baby is asymmetrically small, if it's just brain sparing and it's got uteroplacental insufficiency. So it's a bit more complicated than that, but we can follow these babies pretty accurately and know what's happening. The most important thing is to detect these babies, because then you can intervene, hopefully in advance of anything bad happening. Now, what about growth restriction in pregnancy in smokers? Is it a different thing? Is it the same thing? It's slightly different, and that's important to recognise. Smokers have higher rates of abruption. I do not know why, if they have fetal growth restriction. And they also have a different pattern of fetal growth. So we've had very nice reviews on fetal growth, and a meta-analysis looking at many of these reviews showed a pattern of fetal growth that is different in smokers, and that is that the head circumference is also small in smokers. So you don't get that nice brain-sparing effect. What does that mean? It means that the femur is shorter, the tummy is thinner, and the head size is smaller. I sadly often tell mothers that their baby's head growth won't be as good, because I think that means something. If you were told your baby's brain isn't going to grow as well if you smoke, it might impact on your choice to smoke. And it's also important for people to know, because there's something toxic happening to the baby's brains, and it's not just the placenta. So while the placenta isn't working very well, there's something else at play, and it's possibly neurotoxicity, it is possibly nicotine, or it could be carbon monoxide, or something else that we don't know about, like cadmium. But it's really important to know that. This is a slide taken from the Generation R study, a Dutch study, and this looks at deviations from the standard Z-scores. So they looked at the three parameters I talked about there: femur length, abdominal circumference, biparietal diameter, and they found that measuring in the first trimester, there wasn't too much of a difference. Second trimester, these fell, so they started to drop off. So these smoking babies had lower rates of growth in all of these parameters, and you can see the head circumference is falling off there. And in the third trimester, even more dramatically, so you see a global reduction in baby weights in the third trimester. And what is that? Why is that happening? And the femur length becomes very small. Very often we measure the femur length and it's tiny. And we're going, what's going on here? And it's often they're smoking. It's the thing that I ask first if somebody has a small baby, do you smoke? And they often do. And it is one of the ones that you can intervene about. It's the preventable risk factor if you can persuade women to stop smoking. And that's another challenge. And then I want to move on to stillbirth. And stillbirth is the saddest thing that can happen. I think it's just so difficult. And very often with smokers, and I have to say this, it's not even predictable. And the problem with stillbirth is that if you don't recognise fetal growth restriction, you're going to have an increase in stillbirth. There's also an increased risk of infant mortality. It's highly associated with growth restriction. So if you have growth restriction in a smoker, you're at high risk of stillbirth. If you're a smoker, you're at high risk of stillbirth. But if you have growth restriction, you're even higher. So we do need to monitor these babies by ultrasound. And I think that's really, really important. Again, passive smoking is associated again with an increased risk of stillbirth, and the detection of fetal growth restriction is key. And I just want to say that the other feature of cigarette smoking is that it is overrepresented. Smokers are doubly represented in state claims agencies' claims for massive developmental delay due to birth trauma. So we have a group of women who are red flagged all over the place, but we don't have a single way of dealing with them in pregnancy. A very good study from Gardosi, and apologies for the winding through the first part of the 21st century, but Gardosi's study on stillbirth was seminal. I think he looked at over 90,000 women in the northeast of England, northwest perhaps, and looked at over 400 stillbirths there and found that the risk factors for stillbirth in that population were parity, either being nulliparous or high parity, ethnicity, so poor minority groups, obesity, so if you're over BMI over 30, smoking and growth restriction. He found all of those three modifiable risk factors in that group would be obesity, smoking, and detection of fetal growth restriction. And you can see that if you smoked and you had fetal growth restriction, your stillbirth rate was 13 per thousand. And you can look at the baseline rate is 4, so do the math, so 3 times the amount. However, if you look at non-smokers who had fetal growth restriction, they had a really high rate of stillbirth. And why is that? Well, he, I suppose, showed that if you didn't detect fetal growth restriction, then you had the greatest rate of risk of stillbirth. And thankfully, smokers, being a red flag, some of them, if not all, were being detected, and intervention was reducing the stillbirth rate in that population. Now, I had a vignette, but in the interest of time, I couldn't show it, but it was a patient that we looked after this year. We followed very closely. She was a smoker. We followed her growth. She was on twice weekly surveillance. She came in the day after one of the ultrasounds and she had an abruption and the baby had died. And it makes you wonder what it is that you can do to impact on stillbirth rates. Now, there will be deaths, but you will reduce them if you detect fetal growth restriction. And so, coming on from Gardosi's paper at the end of 2014, the UK Secretary of State for Health launched Saving Babies' Lives campaign, and that was a campaign to reduce stillbirth, which was 1 in 200 in the UK. And part of the tenets of that endeavour was to reduce smoking in pregnancy and to increase assessment and risk and surveillance for at-risk baby, at-risk mothers, so the risks that we just discussed. I want to move a bit sideways again. Now we're going to talk about postnatal. So we've talked about interpartum risks and breastfeeding. But then what about SIDS? In the 1990s, when I was growing up in obstetrics, we were very exercised by the rates of sudden infant death syndrome. And the Back to Sleep campaign then, which was about nursing or sleeping babies on their back rather than prone, significantly reduced the rate of SIDS, which was phenomenal. But when that all reduced, what became apparent was the association between cigarette smoking and SIDS, and it's something like a threefold risk. And so that, I suppose, if you look at this graph, so that it was dose dependent. And the question then becomes why? What causes babies of mothers who smoke or are exposed to cigarette smoke? What makes them not be able to breathe and die? And there's a lot of evidence around, I suppose, the effects of nicotine centrally on neuroreceptors and on the vasomotor activities and heart rate responses, and a lot of stuff that we cannot yet untangle, but does beg the question when we're talking about nicotine. And so I suppose we'll pause there and say that we come up to Sláinte Care 2017, did refocus, I suppose, women's health in the public domain, and that was fantastic. And they did recognise that there were deficiencies in care, and they needed to identify a pathway to help women who smoke in pregnancy. And I think what's really important here is that without data, you're just another person with an opinion. And we really need to promote good research, audit, and look back on our women who smoke, because that's how we will plan for the future. In 2008, Caoimhe Lynch, now a consultant at the Coombe, did an MD thesis with me. She did a little bit of work on smoking. So she looked at 74 smokers and 74 non-smokers, and she found that the rate of very small babies in smokers was about five times higher than non-smokers. And I'm talking about less than the 5th percentile. But they're the babies that are at risk in terms of morbidity. She also found that if you did an ultrasound scan, a single ultrasound scan at 32 weeks, you were better at identifying small babies than symphysiofundal height, than just measuring in the clinic. And it just points to where we should be going with surveillance for fetal growth restriction, generally in obstetrics, because you saw the paper that we talked about from Gardosi, the highest rate was in undetected fetal growth restriction in the population. We need to do better in terms of detecting fetal growth restriction. We need to look at the at-risk people. We may need to approach it generally, but certainly we need to use fetal surveillance for fetal growth restriction in smokers, and that's not always happening yet. Following on from that, Brenda MacDonald took on a PhD to look at a model for care for smoking in pregnancy, but just prior to that, Ciara Reynolds out of the Coombe also published a paper on carbon monoxide testing, and that was a very interesting paper. So Ciara looked at 250 pregnant women. They were recruited, they were given a carbon monoxide breath test, and in her study, 40% of women said they had smoked, 41% weren't smoking. At that time, 17% were smoking. And interestingly, 10% had a positive breath test who said they weren't smoking. So there were a number of women who weren't saying that they were smoking. That's not surprising. What was interesting is that in about 25% of those women, there were adverse effects of smoking seen, such as growth restriction. So there's a hidden group as well. And that's why universal carbon monoxide testing is a very, very good idea and should be. I know it isn't planned to be implemented and is in many units, but not all yet. So Brendan started doing a PhD with us in 2018, and prior to doing that, he decided to look at what was being provided. So he did a nice study on smoking cessation supports in our hospital and found that they were not good. There was not regular carbon monoxide testing. There wasn't, I suppose, often there wasn't even documentation of smoking. There wasn't good clinical follow-up of smokers. There were huge gaps, and I think it's important to acknowledge that that was at that time, and that is not the situation now. But it did show that we needed to improve. And his study also showed some interesting things that are not surprising. So smokers were less likely to have a planned pregnancy. They certainly were less likely to be on folic acid. They were from a greater deprivation area. They were often unemployed. They were of higher parity. They often had a higher rate of illicit drug use, about 25% compared to 6%, and they had 30% rates of perinatal mental health issues compared to 6% in the control group. And I think this describes smokers to a T. So we know these women are troubled, we know that they're disadvantaged, and we know that they need extra support in pregnancy. And an evaluation by Care, not this one, but a previous one, did identify similar gaps. I suppose the Smoke Free Start campaign, which was pioneered by TFI, NWHIP, and I suppose other stakeholders, has done a huge service to obstetrics in providing midwifery-led smoking cessation care in each of the maternity hospitals, and I suppose pioneered first of all in Holles Street and in Cork, and now rolled out to other units including the Rotunda and others, and they do great work in terms of helping this particular portion of women. That has been a huge advantage, and we need to make sure it's rolled out in all the 19 units and works well. And a nice infographic, and this is an example of data which is really useful, shows in the 2 hospitals which pioneered it, they produced results which is really positive. They had 691 women, and you can see the difficulty here is women who don't engage. You cannot really impact if people don't engage, so they had 162 women who did engage, and of those 100 had stopped at 12 weeks. So that's fantastic, and 33 at year end. So I suppose it's very good to have data. That's a very good result in that population. I was often dismayed at our own results in our smoking cessation therapy because it's very hard to get them to quit. But I think if you consider that the difference might be 3% versus 10%, that's a huge difference. And it impacts on their outcomes. So Brendan and I were trying to figure out how to look at growth in pregnant women. And in a conversation with our statistician, we came upon a sort of a novel idea, which was a bit of a light bulb moment, but actually it was so obvious when I think about it afterwards. Why don't we look after these women at a clinic, a single clinic? I mean, if you look at the red flags, if you look at how risky they are, if you look at compared to the diabetic population or compared to another high-risk group, we don't look after smokers in any one clinic. So they're off in different clinics, and they're high risk, and we've just talked about their risks. So we said, okay, we'll randomise these women to a special clinic called the Stop Clinic, a bit unfortunate nomenclature, but that was what it was called, and then to usual care. And usual care was whatever care was being given. We didn't advocate any particular kind of care. And that included whether they're being advised to stop smoking or not. So in our clinic, however, they had, I suppose this was the trial infographic. They had a booking visit. They met with the dedicated stop smoking practitioners. We had Sheila Kyogan, who's a nurse who's trained in smoking cessation, has published a lot with Luke Clancy, and she was very invested in doing that. So she would talk to them in advance, set a quit date, see them after the quit date through the pregnancy. We had a midwife who was given to us by the Coombe, gratis for our clinic. Brendan did the clinic, and I was the consultant associate with the clinic, and we ran it on a shoestring. We got a budget from Friends of the Coombe, so I'd acknowledge that. And I would say this is a really important study, and it is really hard to get funding for any research in pregnancy. And I'd say that's one of the great barriers to the data that we're trying to get. And it is an important topic. So Brendan did that work, and he recruited almost 450 women, 200 odd in each arm. And then at the end, we looked at our results. And this slide probably should be after the next slide, but we'll just talk about birth weight. In the women who didn't smoke, who stopped smoking, the birth weights were similar to normal non-smokers, and the smokers had a lower birth weight. That is not new, that's been seen, but there was a difference in the women that stopped smoking, and that was seen in the centiles as well. Our cessation rates were triple in the clinic compared to controls. Now, it's still only 11%, but still really, really good. And the quitters' birth weights were significantly greater than continued smokers, which you've already said. That's a pretty good outcome in terms of that group. It just speaks to the 88 or 89% that don't quit. Do we leave them out into the great blue yonder, or do we mind them? I suggest that we keep them in the clinic and keep an eye on them. Secondary outcomes, so there wasn't any difference in women who continued to smoke in terms of the number of cigarettes smoked at delivery with the control group, or induction or mode of delivery, or postpartum relapse. Well, we weren't powered in this study to look at stillbirths, so we had 2 stillbirths in the STOP clinic and 3 stillbirths in the control group. And in the women who had stillbirths, 3 out of 5 had placental abruptions. We talked about the risk. Placental abruption risk is very high in smokers, and they cause massive obstetric hemorrhage, and that was significant morbidity for the women. So we switched and looked over a little bit about stillbirth then, because it was a bit dismaying, and this is why doing research is important, because it tells you stuff even if you don't like hearing it. So we weren't able to impact. How can you impact on stillbirth rates in smokers? And this line, the red line in this diagram, is smoking cessation rates over time. So this was a 16-year study, and you can see that we're dropping rapidly in smoking, which is really good. But we haven't impacted on stillbirth rates in smokers. And why is that? That's a question. My own feeling is that it may be related, a dose-related thing. It may also be related to nicotine. It makes me wonder about vaping, and that's the next question. But there are more questions to be answered in regard to smoking. And so on to vaping. So we're in now to vaping territory. We noticed when Brendan was doing his research, and this is the value of a researcher, he said, we're not asking about vaping at the booking questionnaire. And I went, really? We're not asking? No, nobody knew we were not asking. So he put it in as a booking question in the questionnaire. And it's still not on MNCNS, even though we have asked for it to be on MNCNS. And it's such an important thing. But the question becomes, is vaping better? Is it the less of the two evils? Is perfection the enemy of the good? Should we be letting women vape? I haven't got that answer, but we'll have something towards it, hopefully, in a few years' time. So the problem with vapes, the good thing about vapes is they're cleaner. They are cleaner. The problem with vapes is you could be vaping all night and you wouldn't know how much nicotine you're getting. It is like NRT on steroids. So we have to remember that. That's not something I appreciated until my daughter said that to me. She said, you know, vapes, you keep going, and people smoke all the time, and they don't think they're doing any harm. And I think it's a different conversation outside of pregnancy. I'm sorry, but I'm invested in the baby and in the pregnancy. Outside of pregnancy, another conversation. Maybe it's better for reducing cardiovascular risk. Maybe that is perfection being the enemy of the good. But in pregnancy, what we need to know is what are vapes doing to the pregnancy. Now, Brendan, again, in his time, having set up the vaping question, decided he'd look at whether there was any difference between e-cigarette users and non-e-cigarette users and non-smokers in terms of outcomes and smokers. And so he did a prospective cohort study on e-cigarette use. And these outcomes were initially assessed at the booking visit, or the users were initially assessed at the booking visit by the interviews conducted by trained midwives, and we compared them to dual user smokers and non-smokers. And pre-pregnancy, interestingly, so vapers are likely to have a planned pregnancy. They're likely to be taking folic acid. They have a higher socioeconomic group rating. They're likely to be employed. They're less likely to be parous. They're very unlikely to be using illicit drugs, and they have a lower rate of depression or anxiety compared with smokers. In terms of obstetric outcomes, we had an interesting finding, given that there was a lot of conversation and publications around the risks of being small for gestational age with vaping. We didn't find that in this study, and this is a small study and it is a cohort study. It's not enough to know, but we didn't find any difference between e-cigarette users and non-smokers in terms of birth weight, whereas again we saw that smokers were smaller, consistent with the previous findings. And so the birth centiles, likewise, again, lower in smokers, but not in e-cigarettes. So we didn't see growth restriction in vapors. And that's important to say. And so this is data that we've collected and have submitted for publication around an expanded look back on vaping in pregnancy since 2018 to 2022 at the Coombe Hospital. And it's a retrospective study looking at over 33,500 mothers. And they would have had the question about vaping and smoking at their booking visit. And we found that we had exclusive vapors, about 2%. I can't give you a trend over time. I suspect that's going up. Smoker vapors, which is women who vaped and smoked, were about 8.5%, and exclusive smokers 7.85%. In the exclusive vapors, the stillbirth rate is 0.26. Now, at the bottom there is the background rate for stillbirth, and I'd say you have to take into account that that background rate talks about all stillbirths from 24 weeks to term, whereas a lot of the stillbirths in smokers are in the third trimester. And I think if we looked at stillbirth rates in the third trimester, you'd find that this rate is lower, because we know the term stillbirth rate is about 0.9%. So if we say that the stillbirth rate in vapors and non-smokers was 0.3 and 0.2%, that's actually probably equivalent to the background rate. In women who just smoked and didn't vape, the rate was 5.9 per thousand, so that's an increase. In all smokers, so smokers and vapors, that was 6.2 per thousand. But in vapors and smokers, the rate was 0.85, which is 8.5 per thousand. And that's a concern. So is it something that will emerge as being, inaccurate? Is this retrospective data? There's a lot of people who are not catching. Numbers are small, but I'm concerned that it may be related to nicotine. It may be related to the volume of nicotine, and there's lots of reasons why that might be important. But that's why data is important, because it tells us stuff, and then we can look and see, and we are going to look and see. So in the vaping and pregnancy cohort, there was a reduced birth weight, there was reduced gestational age at delivery and early preterm delivery, and increased neonatal admission rates. There's no surprise there. I'm going to move sideways again. I'm going to talk a bit about childhood effects of maternal smoking. So we know that there's an increased risk of childhood cancers in mothers who smoke, particularly CNS tumours, which is unusual. There's also the risk of childhood obesity, diabetes, childhood hypertension, and later metabolic syndrome in adults. And we think that's similar to growth restriction, where we see that in pregnancy, where there's epigenetics occurring